Welcome to Tendo 2016, a worldwide online endo march brought to you by thepelvicexpert.com. My name is Hiba Shahid and I'm a women's health coach and physiotherapist based in Australia, and I'm the founder of The Pelvic Expert. For more information about endometriosis and available programs, head to thepelvicexpert.com and sign up to the mailing list. Women with endometriosis very often experience abdominal and pelvic pain. A lot of the time, this pain persists even after surgery. Sometimes they also experience other pains like headaches and migraine, or sciatica or leg pain. There is a very fascinating connection between the brain, our nerves, and the way we perceive pain. Today, we have two amazing physical therapists, Carolyn Vandyken and Sandra Hilton, in the studio, who will be speaking about something called central pain and sensitization, along with endometriosis. Carolyn has spoken at numerous conferences and presented many workshops internationally on central pain mechanisms and abdominopelvic pain. Carolyn won the prestigious Women of Distinction Award from the YWCA in 2003 for her work in pelvic pain rehabilitation and the OPA's Excellence in Education Award in 2015. Sandy also teaches internationally on the practical application of pain science, imagery, manual therapy, and movement for pelvic health conditions. She's also the co-host of the Pain Science and Sensibility podcast. Both Carolyn and Sandy are the co-authors of Why Pelvic Pain Hurts and several articles and book chapters on persistent pelvic pain. So welcome, Carolyn. Welcome, Sandy.
Thanks, Hiba. Thanks for inviting us to come and speak to or with you today. And we bring you greetings, I guess, from sunny South California, where we're at the Pain Summit Conference, which has been excellent.
We're never done learning.
It's a pleasure to have you both. So we're going to get straight into it, and we're going to be talking about endometriosis and central pain. So just to start off with regards to endometriosis, do we have any stats or rates with regards to pain in the pelvis, pain in the abdomen, leg pain, migraines?
I think statistics are really hard to come by in this patient population from sort of where the patient might hurt. It's quite individual and it can be quite extensive. So there are some statistics available, particularly from the Nickel Tripp group in Kingston, Ontario, that have looked at bladder pain syndrome and IC and where those folks hurt. And what we know about endometriosis, it's a comorbid or a condition that happens alongside with in a lot of people with endometriosis. So I think we can certainly understand that patients can hurt right from their knees to their shoulders and they can get headaches and jaw pain. So it's quite an extensive problem, or it can be, and that's normal.
It is. So if someone comes in with the diagnosis of endometriosis and is also complaining about pain somewhere else, that can be a sign that their body has just become more sensitized. It doesn't mean that now there is something else wrong with that other part too. Because we'll hear that a lot of, well, now my back hurts, or well, now my knee hurts. That must mean something's wrong with those parts.
Have you seen a large connection with women with endometriosis and headaches and migraines as well?
One of the things that we clearly know, I mean, we can talk about where the research shows this, is what Clifford Wolf, who's probably one of the original researchers in central pain mechanism and central sensitization, well back to the 1980s, has actually looked at what the comorbid or the conditions that are most prevalent for central pain mechanisms. And you're going to find conditions that are very consistent with people who have pelvic pain. So endometriosis is on that list. And all that means is that women who have endometriosis are much more likely to have signs of central sensitization. So are migraine headaches. So is temporomandibular joint pain. So is idiopathic low back pain, which just means low back pain for no specific cause. So are restless leg syndrome. So you're seeing a constellation of syndromes that have, what they have in common is a sensitive nervous system.
And have you also seen, and from what I've heard as well, is even visceral things like irritable bowel syndrome, that there's a connection between that and the central nervous system?
Definitely. There's, I think we need to get comfortable of not separating it out, that we have to continue to look at that whole person, because the suffering that they're experiencing. We just heard Kevin Bowles talk, and that's an important component of this as well. It's not just the endometrial tissue; it's the effect that has on their entire nervous system, and certainly the crosstalk with the organs is going to come into play.
Everything communicates really at the spinal. That's okay. Everything communicates at the spinal cord, and this area, particularly the pelvis. What makes pelvic pain interesting and challenging, and sometimes difficult for patients to live with, is that all the functions in the pelvis need to be really well coordinated, right? So both from voiding, elimination, peeing, and pooping, if we want to just say that really simply, or sexual function, arousal, orgasm, all of those things need to be highly coordinated, and that happens in the spinal cord. And so there's a lot of crosstalk between those functions in the spinal cord, and when one area gets sensitized, so do the others.
Absolutely. So can you just explain to our viewers, what is central sensitization?
Carolyn's looking at me. Excellent.
I can do it.
My turn. No, to put it as simply as possible, it's a ramping up of the sensitivity of ourselves, so where information coming in to your brain, for lack of another way to call that, would be taken more excitedly than it would normally be. It's like if you get, I use the metaphor of being in a car with a bunch of 8-year-old boys. If there's one 8-year-old boy telling fart jokes, it doesn't bother me as much. But if there's 5 or 6 of them, it bothers me easier and faster, and I get irritable for longer. That's an upregulation of my nervous system. Central sensitization starts immediately after injury. It's a normal thing. What's not normal is it persisting. So it's normal for our body to protect us against injury or the perception of injury, but that's supposed to go away. And when pain or abnormal movements or pressures from endometrial tissue continues over 3 months, then there is some change in the nervous system itself. The good news is it can be changed back to an extent. So you're not stuck like that, but there will be a need to address ways to calm your whole nervous system down. You get more agitated than normal.
Another analogy that's commonly used is the one of an alarm system, right? So the central nervous system, the brain, the spinal cord are really an alarm system, right? Pain is a defensive mechanism. And if we had an alarm on our house and it was only supposed to be designed to go off when a burglar came in, that would be a really good alarm system, and we'd be very appreciative for that alarm system. But if that alarm system became really sensitive, there was some sort of default in the system, and every time a leaf blew by the window, the alarm went off, it would get pretty annoying pretty quickly. And we'd learn not to be able to trust that alarm system, right? And that's kind of what happens with patients with central sensitization, is their nerves become more and more sensitive, both perhaps in the periphery outside of the spinal cord and inside the spinal cord. And so things that might normally just feel like touch all of a sudden get ramped up, and a pain experience can be produced.
Yes, so basically we're saying that the brain and the nerves become a little bit more sensitive, they become a little bit more hyper irritable and hyper excitable, and so they're sending off these danger signals for things that they really shouldn't be,
right,
because the whole body is so sensitized. Right. And I really like that alarm system analogy, and definitely as well the fart jokes analogy as well.
We can all relate to that.
I don't like being in a car with a lot of 8-year-old boys.
And what about peripheral sensitization? What can you tell the viewers about peripheral sensitization?
It's actually a component of central sensitization, because we have both the peripheral and central nerves. But they're two-way streets, the nerves. They don't just go with information from the outside, from like our fingers in. There's also information coming from the top down. And the peripheral nerves can get inflamed, and the muscles around them can be kind of held in a little bit of spasm or extra guarding. And at the spinal cord level, just outside the spine, the dorsal root ganglion, we'll get very technical here, gets really highly sensitized, so that movement and pressure and changes in chemicals bother it quicker and for longer than it should. So it's very much the same. I think perhaps we're going to stop calling it peripheral or central sensitization and just call it sensitization.
Peripheral sensitization generally tends to be a little bit more specific, Sandy, would you say, along sort of a more specific pathway, whereas central sensitization probably is a more global, diffuse type of sensitization that occurs. So when you see sensitization or pain that started on one side of the body, now it's on the other side of the body, and now it's maybe, you know, we're talking the legs, and now it's in the shoulder and the neck, that would be more a central sensitized problem.
And typically as time goes on, that can happen more often, but not always. So it's not necessarily time-based.
Right, right.
Yeah, I agree. And I suppose a good analogy as well is for women with endometriosis, oftentimes a peripheral sensitization issue might be that they might be experiencing more vulvodynia type symptoms, more focused just in that labia sort of area.
Perhaps, although, you know, there's some good research, particularly if you're interested in the vulvodynia piece, more specifically, Carolyn Vandyken, another Canadian from Kingston, Ontario, has done a beautiful series of studies looking at, is vulvar pain, vulvodynia, is it a peripheral problem? Is it in the tissues of the vulva? Is it a more of a central problem? And I'm missing one stage.
Elsewhere in the body.
Right, so more of a diffuse problem, right? So she found
people in the studies also had pain, just as you mentioned earlier, like through the shoulder, through the low back, across the abdomen. So it's not localized just to that one spot.
Right. So because pain is localized doesn't mean it's not a central problem. I guess that's the point I wanted to make with that. Sometimes central pain can be very diffuse, and sometimes it can be very localized, but still being driven predominantly by the central nervous system.
Yeah, thank you for that. So my next question for you is, why do women with endometriosis have pelvic pain? And are there any other protective mechanisms that they can exhibit?
I think there are people that have endometrial tissue that don't hurt, so that's good news. And there are people with endometrial tissue that have abdominal pain or suprapubic pain, but not so much perineal pain. The patterns are highly individual. The good news I take out of that is that we can modify it somehow through a whole lot of different interventions, not just physical therapy, but so you can have pelvic pain with endometriosis, but you don't necessarily have pelvic pain with endometriosis.
And you can have visceral sensitivity. So we already talked about the IBS patients and how they can be interlinked. So your organs can become very sensitized. Your pelvic floor can become sensitized, that it becomes very tender. And we like to call that sort of an over-recruitment, perhaps. Tends to be with endometriosis. We see more over-recruitment than under-recruitment. So these are generally the women we don't tend to do a lot of strengthening with necessarily, but maybe some women do need that piece as well. So it is highly individualized, and we need to consider the tissue piece in endometriosis and tension within the tissues as much as the central piece as well. So
yeah, and I think one of the reasons it can be challenging is because it's a constant thing, right? The tissues are in there and they're taking up some space and putting pressure on something in areas that might not be well received by the body. And one thing that we know, much like with fibromyalgia, is that a carefully graded exercise and consistent activity is really helpful. And that's a hard thing sometimes for someone that is in pain to hear, is that one of the ways you can get better is to move more. But that needs to be carefully designed and very individual. You can't just say, okay, all of you go walk for half an hour a day. But that can help a lot, even if you're having pelvic pain and you think that intuitively that would make it worse. It actually helps.
Yes, thank you. And the last question that I have for you today is, how can understanding pain reduce pain? Can we give some tips and advice to our viewers?
Start?
Sure. I think that one of the the handiest tools about understanding pain is it helps to not be discomforted or afraid of what you're feeling. That you can put some sense to it and feel more confident that you're okay and safe to move. That's incredibly helpful, because there are going to be days where you're just tired and exhausted and don't want to, and you hurt, and this all stops making sense. So really understanding deeply that the pain does not mean that you're damaged or that you're going to do damage by moving or anything, that you're inherently safe.
I think as well, if you understand that your nervous system has become sensitized, it's a bit reassuring to know as well that there are ways to help your nervous system become less sensitive. And if you get some help with that, and you know that that's the target of your treatment, there's less fear involved, right? Pain is produced when you feel threat of some sort, when you feel like there's some challenge to your tissues or to your system that you're not capable of meeting. And when you understand how that system works, which is what pain neuroscience education or pain biology education is, that helps to de-threaten that process for patients.
So what kind of things can patients do to reduce their pain?
Things they enjoy. That sounds like a toss-off answer, but it truly is. It's nice to balance what you do for yourself with some things that are more on the calming, quiet, meditative side, like a constructive rest position where you get in a very comfortable position and spend some time on breathing techniques or mindfulness techniques. It needs to be something you like and that fits well with your understanding of what feels good.
Just to comment on that before Sandy goes to the next point, which I know she's going to, but I think one of the things that we all understand is that when we acutely hurt ourselves, like we cut our finger, we immediately take care of the problem. And when we immediately take care of the problem, let's say I cut my finger when I'm chopping vegetables, I go to the sink, I rinse the cut, I examine the cut, I stop the bleeding, I decide whether or not I need stitches. Okay, I don't need stitches, I put a bandage on, right? And once I put a bandage on, several hours later, that cut doesn't hurt anymore. But if I took that bandage off carefully, it hasn't healed yet at all. So for patients to understand that tissue injury can be there much longer than actually pain. But one of the reasons for that is because the brain now knows you took care of that problem. You put a bandage on, you make sure you didn't need stitches, right? I think in persistent pain, we fail to soothe the pain. And soothing the pain isn't staying in bed. Soothing the pain is finding ways to move or engage again in life, or a constructive rest position, as Sandy was talking about, that actually helps to reduce your pain and helps to get you control of the pain. And once the brain understands that you've done something to address the problem, it's going to start to quiet those alarms. But as long as we continue to ignore it and push through it, the alarm bells often keep ringing louder and louder.
They can. And so the balance is to find some time that calms things down, and also some time to challenge yourself to move and get good blood flow, good blood supply, get your heart rate up. All of those things we know are necessary for fitness. It starts to sound just like being back in high school and phys ed class of eat good food, drink enough water, get plenty of exercise every day. Those are all sustaining and helpful ideas.
And get some help with sleep. But then also don't worry about sleep. If we don't sleep for a period of time, our bodies will catch up. Our bodies will take what it needs at that point. So sometimes I think the stress about not sleeping creates more sleeping problems than the not sleeping itself. Although it can be very distressing at 2 in the morning when you're not sleeping. But, practice good sleep hygiene, get some help with the sleep piece, and start to work towards improving your sleep, because that will help you feel better as well.
And I'd just like to add, definitely there's a lot of different strategies that you can do to bring down central pain. And one of the first things is really understanding pain. And so the great thing is that Carolyn and Sandy have co-written a book called Why Pelvic Pain Hurts. And just even reading that book is going to just help you understand why it is that you're feeling pain. And that in itself is going to start to dull the sensations of pain. And then, of course, as Carolyn and Sandy were mentioning, movement. So any type of gentle movement to start off with, and then you can slowly build up to things that you enjoy. So things like you can start with some gentle yoga. You might just do some meditation, relaxation type exercises. And I like the point of that Sandy raised about meditative practice and taking that time to take deep breaths. We know that deep breathing helps to relax the central nervous system. And so we find that a lot of women with pain often are not taking deep breaths. They're taking those shallow, anxious type breaths. And we want to bring down that sensitivity by taking those deep breaths and allowing the nerves to just slide and glide through the tissues a little bit easier. Would you agree?
Absolutely. Yes. Well said. Well said.
We need to.
And we need to make it less scary, right? So really finding ways to kind of understand your pain and you know, try to struggle against it a little bit less, right? It's that struggling and that suffering piece that we know from many research studies actually increases the sensitivity of the system, right? So understanding it, be okay with where you are today, knowing that as you move and do a little bit more, tomorrow or the next day or a month from now is going to start to look a bit different, and having that hope, believing that you can be well. I think that's very important.
It's really important.
Yeah, and I think as well, that, as you were saying, just to add, some distraction techniques are always good. So distraction technique, and I've seen this with also a lot of women that come into my clinic. When they're spending time with their friends or with their partners, they do feel much better. And that's just because you're taking the focus away from those tags in your brain that are just focused on the pain. So it's just shifting your mindset from a pain focus to a future focus, like what can I do, where am I, not being so aware of the pain, but being aware of things around you, being aware of other emotions that you feel with people that you enjoy spending time with as well.
What are, you know, I guess another good way to look at it is, what are your values, right? What is important to you? How do you want to live your life? And starting to claim that life back again, and understand sort of, and you may need some help to get there, but every day sort of setting another goal to just do a little bit more than the day before, just a bit, right? Just one more minute of something. That's all it takes.
Yeah, there's a lot of hope out there. People can get better.
Exactly right. Well, that's all we've got time for today. I'd like to thank Sandy and Carolyn for joining me today to speak about central pain. And I hope the viewers have learned a little bit about central pain. And if you feel like you need to know more, definitely head over to Amazon.com and see if you can purchase the Why Pelvic Pain Hurts. There's also a few other great guides. A book by David Butler called Explain Pain, which is very effective in explaining the whole process of pain, and which has made a big difference even in my life. And I'd just like to take a moment to ask Carolyn and Sandy if you could give some details about where viewers might be able to contact you or find out more information through your website.
So I'm in Canada, in Ontario specifically. We have a teaching website. Myself and Nellie Fagani have a teaching company, and we teach pelvic courses to physiotherapists and midwives and physicians. And so pelvichealthsolutions.ca would be our website. We try and put a lot of information on that website for patient education as well. So patients hopefully can learn a lot by just visiting the website.
And I am at entropy-physio.com. It's a physical therapy clinic in Chicago. If you want to find me online, I'm easiest found on Twitter at Sandy Hilton PT. I think I live there.
She does, but it's a great place to live because I get all the research that she digs up.
Yes, thank you. And if you'd like to know more, you can head over to the social media sites of The Pelvic Expert, but also to the website, thepelvicexpert.com, and you can sign up for our free ebook on endometriosis as well. Thank you for joining us, and we'll see you at the next interview.